up. You know the way they talk about, kini yen payan, oloshi, otiku. The only thing they know is otiku. You know, really, otiku. But now, medicine has advanced. Medicine has moved to that place where they may not even need to cut you. I think they call it laparoscopy or something. Sir, am I correct, sir? Where they can just go through the abdomen, if I'm correct. Then they take whatever it is they need to take out. And some of us have had to go under the knife for major surgeries. I don't know what they call it. Something myomectomy. Thank you very much. You have to do that. I've gone through it. I didn't tell my mother. Because before she dies now, you know, by telling her alone, she can just pass out. Yay! Because everybody she knows, you know, Otiku, that's the end. Otiku, that's the end. But that is not the case anymore. So this afternoon, we're bringing up someone who is going to tell us exactly, from his years of experience, he's been passionate about it. Women, the infertility areas, who has had joy at the results it has brought to him over the years. He's practiced for 41 good years. I was not even born when he started, you can imagine. And I'm introducing him today. Such a big privilege. You know, and he has had challenging times having to see that many people took too long to take the right step. At that point, if you had gone earlier, maybe the chances are you could have been helped. So I'd like to read the bio of our professor. Professor, sir, I'm deeply, deeply honored to do this today. I know what it means to be a professor, to go that far. He's a professor and head department of obstetrics and gynecology, College of Medicine, University of Lagos. He's a head unit of productive, endocrinology and fertility regulation, College of Medicine, University of Lagos. He's a consultant O&G from Lagos University Teaching Hospital, Idiaraba, Lagos. He's also the head of the Luth IVF Center. If you are clapping, clap well. He's the medical director and consultant gynecologist, Magodo Specialist Hospital, Magodo GRA, Lagos. He's the director, Magodo Fertility Center, Magodo GRA, Lagos. He graduated from the College of Medicine, University of Lagos, Idiaraba, in 1984. He completed the residency training program in 1994 and was awarded Fellowship of the West African College of Surgeons and Fellowship of the Nigerian Postgraduate Medical College. I'm sorry I can't cut this short. I would have to read it through. He's earned it. Please bear with me. He won the Society of Gynecology and Obstetrics of Nigeria Award for being the best candidate in the Part 2 final FMCOG examinations. Professor Olamijulo traveled to the United Kingdom for higher specialist training in 1994. He became a member of the Royal College of Obstetricians and Gynecologists, London in 1996. He completed the UK Higher Specialist Training Program and was awarded the Certificate of Completion of Specialist Training in 2001. He was appointed a full-time consultant gynecologist in the UK National Health Service, NHS. Those of us that want to jackpot is here. He won the Level 2 Award for Clinical Excellence in 2005. He became a fellow of the Royal College of Obstetricians and Gynecologists in 2008. Professor Olamijulo returned to Nigeria in 2008 to join the services of his alma mater, the College of Medicine, University of Lagos, and the Lagos University Teaching Hospital. He has been involved in the training and mentoring of medical students and postgraduate doctors undergoing residency, specialist training, as well as delivery of high specialized clinical care. We are in safe hands this afternoon. His subspecialist interests are infertility, including assisted reproductive technology and gynecological endoscopic surgery. He is the medical director of Magodo Specialist Hospital. Professor Olamijulo, right now, you know, he's well seasoned with all the spices you can think of, the fresh and the dried spices. He's committed to excellent patient care. He's a fellow of the National Postgraduate Medical College of Nigeria, fellow of the West African College of Surgeons, fellow of the Royal College of Obstetricians and Gynecologists, London. He's a member of the Association of Fertility and Reproductive Health, member of the British Society of Gynecological Endoscopists, and a member of the European Society of Gynecological Endoscopists. Yes, he is simple, he's patient, he's friendly, He's very approachable. He's a Christian, and he's a worker, and he's a pastor of the Redeemed Christian Church of God, Victory Chapel. Chosen women, can we put our hands together for this well-seasoned, all-round, God-loving, God-blessed, smart, intelligent, what else would I say? We can do better. Please, can we be on our feet? He has earned it. I'm privileged, sir. Very privileged to welcome you here. Let's put our hands together. Thank you, sir. Be prepared. Please, we can do better than that. Please. Thank you. Thank you very much, sir.
Hallelujah. Oh, be lifted above all the gods. We lay our crown and worship you. Oh, be lifted above all the gods. We lay our crowns and worship you. Oh, glorious God, we praise your name. We lay our crowns and worship you. We give you all the glory. We give you honor. We give you all the glory. We give you honor. Praise God. Hallelujah. Praise God. Amen. Praise God. Hallelujah. Praise God. Amen. Our Father in heaven, we worship you. We give you praise, we give you honor, we give you adoration. We thank you for another year of the All Sisters Conference, and we thank you for all your blessings. Father, you are the author of knowledge, understanding, and wisdom. We pray, Lord, that you grant me utterance and you grant your people understanding and wisdom, and you take all the glory. In Jesus' mighty name we pray. Hallelujah. Please be seated. We thank the Almighty God for the privilege. We want to say thank you to Mrs. Kemi Badejo, who has been constantly contacting me. And I want to congratulate everyone here present and congratulate you for being part of this year's conference. I pray that the blessings earmarked for each and every one of us will not elude us. In Jesus' name. Because God said it's not good for the man to be alone, I am not only here, I'm here also in company of my beautiful wife, Mrs. Folakemi Olamijulo. God bless you. I don't know, I've shared my slides with the media. If they can bring the slides up, that would be great. My name is Professor Joseph Olamijulo. I'm a professor of obstetrics and gynecology at the College of Medicine, University of Lagos, as well as a honorary consultant at the Lagos University Teaching Hospital. Some of the details had already been communicated with us. By the grace of God, I also run the Bagodo Specialist Hospital as well as the Bagodo Fertility Center. Now, I've been asked to talk about the topic from womb to wisdom, navigating fibroids, menopause, and the postpartum journey. This is a multifaceted topic. It virtually covers all that I've studied, I've learned, and practiced over the last 40 years. Yet I have probably about 40 minutes to discuss this. So I'm trusting God to help me to know what to include and what to exclude. But I believe that there will be opportunities for questions and answer at the end so that we can fill in the gap. Next slide, please. Okay, so we're looking at the journey from infancy through the teenage years, through adulthood, and the menopausal years and the post-menopausal years. So it's a big topic, but we will be using this outline. Can we have the next slide? We'll be looking at the key life stages as far as reproductive health is concerned. The journey actually starts from prenatal life. I'll be looking at that. That is even before, the female child is born, and goes through infancy and childhood, and then the big elephant in the room is the reproductive life, whereby we have issues of sexuality, fertility, pregnancy, and childbirth, menopause and beyond, and then we can draw some conclusions. Next slide, please. Now, God's own plan for us is that we will enjoy good health. I was lucky to be part of the last session, and I think there was a lot of revelation there. But a commonly referred to is 3 John 2. 3 John 2. There's only one chapter in 3 John. And it says that, dear friend, I pray that you may enjoy good health and that all may go with you, even as your soul is getting along well. But similarly, Romans 15:13, which is your theme, for this year's conference, talking about abounding in hope. Again, a similar expression of God's desire is recorded in Jeremiah 29:11, where God said that his thoughts towards us are good and not evil, to give us hope. And this solidly agrees with your the theme for this year's conference. Next slide, please. Now, from womb to wisdom, like I said, the journey does not start even from infancy. It starts from the womb. Okay, there is a difference how the male child or male baby develops and the female baby develops. So we will see that shortly when we look at the ovarian capita, and then the various stages we have outlined. Next slide, please. Now let's look a little bit at the ovarian capita. Psalm 139 verse 13 says, you knit me together in my mother's womb. And verse 14 goes on to say that I will praise you because I'm fearfully and wonderfully made. we have been fearfully and wonderfully made. The God of all flesh, the creator of heaven and earth, has given the woman 2 ovaries in prenatal life. Like I said, it develops differently from the male gonads. The difference is that there is multiplication of the cells. You know, the human body started from 1 cell, and 1 became 2, and so on and so forth. And then the cells began to differentiate into various specialized organs. And one of the most important organs, of course, what makes us female, are the ovaries, and there are 2 of them. And the cells, which we call primary oocytes, these are the eggs that go on, to become very important in life. Now, the ovaries is not only about production of eggs, but also production of hormones that make us the women that we are. Now, the maximum number of eggs, which is about 20 million, is reached about 20 weeks of intrauterine life. That is when the baby is still in the mother's womb. So, and after that, the number begins to dwindle. By the time the baby is born, you have only about 2 million oocytes that's available. And then through infancy, and then through puberty, and then when puberty comes, the secondary sexual parts become developed. The woman begins to menstruate and to ovulate. Now, on average, only 1 egg is released per month, per menstrual cycle. However, thousands are recruited. And what happens to the rest? They become atretic. And this is how a number of eggs begin to decline throughout life. And that reaches a critical number in the 40s. And that is when, you have premenopause. And then after that, when the eggs have actually exhausted, then you have menopause. So 2 implications. One is that at that stage, the number of eggs have been depleted. But also, the capacity to form the hormones, the estrogen hormone particularly, also has declined. And this is the reason why women become menopausal, and also why they no longer are able to get pregnant spontaneously. So it is important to understand this, to understand that there is an ovarian capital. It's like you have a bag containing money, and you are spending from that bag, and you are not putting anything back. So at some point, there will be nothing left. And that's the story of, the journey to menopause. Next slide, please. So, with that understanding of what happens even in intrauterine life, we can move on to what happens in infancy. Infancy is a period from birth to puberty. It's characterized by rapid physical and cognitive development. At puberty, the stage marks the beginning of sexual maturation, with hormones changes leading to development of secondary sexual characteristics and the onset of menstruation. But there are other things that are going on. Now, at this stage, what do we need to do? Most of us, virtually all of us, we've passed that stage, but we have daughters, we have nieces and all that are going through that stage. It's important that we pay good attention to nutrition and hygiene, because this affects the development subsequently and the reproductive health subsequently. The education of the female child is very, very crucial because this is important when it comes to female empowerment. Now, it's not only the formal education, which is very important, but also sex education. And I think we've had much talk about that today. Sex education is very important, as well as spiritual development. Proverbs 22, verse 6, talk about teaching your child, the way, training up the child the way it should follow, so that when they grow up, they will not depart. Similarly, Proverbs 29, verse 17, talks about, this one, it talks about teaching your son, but I believe it also applies to your daughter, and that he will give you rest. So we need to take these steps for our world, so that in later life, some of the mistakes that will become a problem does not become a problem for them. Praise the Lord. So the next slide, please. Now, the elephant in the room is the reproductive age group. And typically, we say this is between age 15 and age 45. And the issues here are, issues of sexuality. Again, I think we've had a good dose of that today. But some of the hanging issues are the issues of unprotected sex, sexually transmitted infection, and unwanted pregnancy, especially in the teenage years. And this can adversely impact on what happens later. Some women now are infertile because of mistakes that were made earlier on. Issues of unwanted pregnancy, termination of pregnancy, and so on and so forth. So it's not just about spirituality, but also about the consequences of what happens later. And of course, infertility can be a big issue. It is fairly prevalent. We will talk about that shortly. The issue of fertility. We will look at the causes and the treatment. Pregnancy and childbirth, of course, very important. And that's where the journey, navigating the journey in the postpartum period comes on. Next slide, please. So briefly about infertility. You and I, we know one or more people with issues with delayed fertility. Okay, either a friend, a family friend, or family member accomplished, or we ourselves. So it's estimated that 1 in 6 of couples are affected by infertility. So it is important because we place so much premium on fertility. God himself wants us to be productive. Genesis 1:29 talks about being fruitful, being fruitful and having dominion. So now the important things to know is that the causes, the main causes of fertility, tuber blockage is the commonest cause in our environment, and that is as a result of tumor damage. I mentioned before the issue of unsafe sex. Okay, the issue of unsafe sex. So because of infection, 2 major causes of infection are sexually transmitted infections. So avoiding unsafe sex is not just about avoiding pregnancy. It's also about avoiding sexually transmitted infection. The other, infection with gonorrhea and chlamydia, as well as post-abortal complication. When people have had termination of pregnancy done in all sorts of places, some of these stories, they can become infected and subsequently suffer from tuber damage. And of course, fibroids, we will have some few more words about fibroids. It is an important cause of infertility in our environment, but you also should know that it's not every fibroid that causes infertility. As a matter of fact, there are some women who don't know they have fibroids until they are doing their pregnancy scan, and then they find that, they have some fibroids. There is also the problem of intrauterine adhesions and ovulation, which means not producing or releasing eggs. Then male factor infertility. I had the privilege of, giving a talk here about 2 years ago on male factor infertility. Oftentimes people think it's the female because we live in a paternalistic society. So it's like, oh, you go and check yourself first. Whereas the man may be the issue. So it's important that, couples should be investigated, evaluated together. Otherwise, you will be, you'll be acting amiss. You'll be treating the wrong thing if you don't inform, and wasting time if you don't involve the male partner. And then there are other minor causes such as endometriosis and so on. So it's important to evaluate both the male and the female together, to do the necessary investigations focused at detecting what the issue is, because the cause of infertility is not the same in every couple. For some, it may be tubal blockage. So if you are giving those ones ovulation induction drugs, you are wasting your time. Okay? So we need to investigate and determine what the problem is, and of course the treatment will be based on the problem. Now, IVF has revolutionized the treatment of infertility, especially tubal infertility, which is the commonest in our environment. What it has also done is that the barrier on age has now been lifted. So it's not unusual now to hear that a woman who has stopped menstruating, who has reached menopause, who is in her 50s, has given birth to twins. So, and that is what technology has done. Next slide, please. Next slide. Okay, so now because fibroids is a recurring factor in all this. It has a role to play in infertility and other female reproductive health issues. Now, what are fibroids? One is to know that they are non-cancerous, okay? They are growths in the uterus. They are not cancer. And then they occur fairly commonly. Depending on what data you are reading, they said 20 to 40% in women in their reproductive age group, which means at least about 1 in every 3 of us sitting down has fibroids. Okay, but like I mentioned before, it's not every fibroid that has problem. Unfortunately, we really have not been able to say this is the real cause of fibroids. Okay, but we know that it's commoner in we blacks. It's also associated with some genetic disposition. You find that sometimes mother had fibroid, and therefore some of the daughters also have fibroids. It responds to hormones and some environmental factors. Now, how does it present? Like I said, some people have fibroids and they don't know. They don't, because it's not causing them any problem whatsoever. So it can be asymptomatic. Now, but the commoner presenting features include menstrual problems, usually heavy periods. Heavy periods, or sometimes bleeding in between the periods, passing clots, flooding, and so on and so forth. And sometimes it can be a reason for a woman becoming anemic, just feeling tired, and sometimes passing out. So, but perhaps the most popular, that we are aware is the issue of fertility. It can affect fertility. Now, the picture we have actually shows this would not basically the various locations where fibroids can be, which is also important because it's not just the size, but it's also the location. Now you can see this one, this is the lining of the womb, and this is where implantation of the embryo occurs, following fertilization. So if you have a fibroid here, which is inside the wall of the uterus, it's not likely or is less likely to be a problem compared with this one that is pushing into the cavity. So the location of the fibroids is important. So fertility can be a problem, but again, like I said, it's not every fibroid that causes infertility. Also recurrent pregnancy loss. It can affect, in pregnancy can be a cause of pain, can affect positioning of the baby, and so on and so forth. It can also cause pressure problems, and also it can cause abdominal swelling. Next slide, please. Next slide. Okay, so management depends on the presentation. So if it's not causing problem, if it's not broken, don't fix it. So there is no need in many cases, just observe. It will also depend on the age. There are, for instance, if you find fibroids in a woman who is already menopausal, she's had all her children, she's not having any problem, then let her live with it. You don't need to do anything about it. And also desire. Again, even those in the reproductive age group, if they have fibroids that's causing them problem, if they have already had their babies and they don't want any more, then you can offer them hysterectomy, which means remove the womb. Whereas, if they haven't had their babies or they still want to have more babies, then you need to preserve the womb by taking the fibroids out, one way or another. So sometimes we use drugs to reduce the bleeding and to correct anemia. As was mentioned during I think it was the question and answer session, about surgical options to fibroids, managing fibroids. Mammectomy means you leave the womb there, but you remove the fibroids, because you still need the womb to carry the babies. Whereas hysterectomy means removing the uterus. Again, as was indicated, in the years past, everything used to be open surgery. You have to cut the abdomen and get, whatever you need to do to get it done. But much of this can be done through keyhole surgery now. Laparoscopy or hysteroscopy. Hysteroscopy means actually going through, no incision whatsoever, but going through the vagina and through the cervix, and then taking the fibroids out, especially those that are submucosal, that is the ones that are close to the inside of the cavity. There are other, treatment options, not very common in our environment. Embolization, which means you can use radiological techniques to occlude the blood supply to the uterus. And by so doing, it makes, you are depriving the fibroid nutrients, and therefore it will shrink over time. So there is that, and there is HIFO, which is high intensity focused ultrasound treatment. Like I said, these are not, they are still being evaluated. They are not suitable in every situation, and they are not commonly available in our environment, and they are very expensive. Now, just a word of caution. Now, one major thing with fibroids is that, or generally in our environment, is the fear of surgery. No, the aversion for surgery. Once you mention operation, some people will just disappear. And the problem is that then if you find someone who tells you that, oh, no, you don't need an operation. All you need is, there are these women that I understand prescribe some caustic materials for them to put in their vagina, telling them that what I will do will be to melt the fibroid. And that sounds very attractive because that means, bingo, you don't have to have surgery. But what then happens is that over the next couple of weeks, they are bleeding with severe pain in their vagina. Now, these are caustic materials, which is like acid, put into the vagina. And we see the consequences of this in our practice, especially in the teaching hospital. And they'll say, oh, it's the fibroid that is melting. But unfortunately, it's the vagina that is melting. And what then happens, if you have seen somebody they have poured acid on before, the healing, it heals with contraction. So what then happens is that the vagina closes up altogether. And it will require very complicated surgery for us to reverse that. And you know what? The fibroids will still be there, untouched. So we've had issues with this. And unfortunately, these women that, prescribe this sort of treatment, the next victim will go there. People don't tell them that don't go there, because they are ashamed of their own experience and all that, and so on and so forth. So please, while you have the right not to have surgery and to explore alternative treatment modalities, please don't be a victim of societal evil. Next slide, please. And like I said, actually surgery is generally safe now, provided you go to the right place. If money is an issue, the teaching hospitals, are generally safe because you have experts there. The general hospitals are generally safe and people are under. But if you go to a ramshackle place, may we not become victims. Now, family planning, just a quick touch on family planning. The flip side of fertility is family planning, of infertility is family planning. So you want to control unwanted or prevent unwanted pregnancy. So, we are not like rabbits. So God has given us knowledge to be able to separate the act of sexual intercourse from the act of conception. So we should be able to, determine how many children we want to have and spacing them as well. So family planning is to limit the number of children and also to space the children that we have. Of course, there are myths. Oh, don't use family planning. Oh, you will get cancer, and so on and so forth. These are unfounded myths. There are clear benefits for maternal health, for child health, and the data is there to support this. It prevents dangerous pregnancies. There are some people, either because of their health, that shouldn't get pregnant. But should they not have intercourse? Or there are some people who have had too many pregnancies, and then pregnancy becomes a danger to them. So family planning can help. Now, so the other benefit is that some family planning methods such as condom, prevent sexually transmitted infection. It can also make the periods to become more regular and so on and so forth. So, and it gives you that comfort, you don't need to fear. And of course, there are huge economic benefits in today's Nigeria. we know what the economy is saying. Now, the ideal family planning method should be very effective, 100%. When you use it, you shouldn't get pregnant. It should be completely safe. No side effects, no danger at all. It should be available easily. It should be acceptable both religiously and culturally. It should be affordable. I think affordability is a main issue, given the level of, the fact that the vast majority of our population are living under poverty line. So these are issues. So there is no ideal one. But we have a lot of methods that we can choose from. Most of them, they are virtually all safe. But if one doesn't agree with you, in consultation with your doctor or your family planning nurse, you can choose which one is suitable for you. Now, pregnancy and childbirth. So we thank God the woman has got pregnant now. So what is next? Now, pregnancy is not a disease, but is a special state of health. It's a peculiar state of health. And potentially things can go wrong. It's not over until it's over. There are lots of physiological changes that is occurring in the woman's body, mostly modulated by hormones during pregnancy. And it's important for women to be educated to know which one is normal and which one is abnormal. Now, it's important that pregnant women book for antenatal care so that they can be counseled appropriately. There are some things we can prevent during the course of antenatal care. You can prevent anemia, you can prevent malaria, and so on and so forth. There are some conditions that if you detect them early, you can take steps to mitigate their effects. For instance, hypertensive diseases in pregnancy, which is one of the commonest causes of morbidity and mortality. So it's important that women attend proper antenatal clinic. Now, intrapartum care. One of the key things that has been established is the fact that women are less likely to suffer injury or to die if they have supervised intrapartum care. Supervised intrapartum care doesn't mean it has to be in the teaching hospital. So if you have your good primary care center, where they've seen you during antenatal period, they can handle most cases. And if there is any need to refer, they will refer. Majority or most women will deliver, like the Hebrew women, normal delivery. However, some will need assistance. What matters, in those days, certainly when I first started obstetrics and gynecology, when you tell a woman, oh, you need a cesarean section, they will begin to reject it and start asking, who have they offended? But at the end of the day, what matters is for you to be alive and well, and for your baby also to be alive and well. So that is the bottom line. So if you need to be assisted, either with instrumental delivery or cesarean section, please don't revolt. Okay? And then we talk about the postpartum period, which was one of the highlights of my invitation. During the postpartum period, which is the immediate period after childbirth, there are physical and emotional health issues, and also the care of the newborn. Next slide. So we talk briefly about the postpartum period. This is the period where the woman's body goes through many physical and emotional changes. It's usually the immediate ones, a period of about 6 weeks when things begin to return to the pre-pregnancy state. although it doesn't completely return, to the pre-pregnancy state. The journey comes in 3 phases. There is the acute phase, which is the first 12 hours or so, when there could be medical emergencies such as, bleeding, collapse, and things like that. And then the subacute, which is 24 hours to 6 weeks, where you can have infection, you can have maternity blues, depression, and so on. And then you can also have issues with care of the newborn. So it's an important phase where there is a lot of physical and emotional issues to address. And of course, subsequently, you find that there may be some delay issues arising from delivery, such as pelvic floor dysfunction, painful sex, prolapse, and things like that. Next slide, please. So during the postnatal or the postpartum period, there are some warning signs that probably we should take note of. Heavy vaginal bleeding can be an issue. Hemorrhage, by the way, and I will have a quick run through maternal mortality and morbidity. Bleeding is the leading cause of maternal death. Bleeding, that's worldwide. Bleeding is the leading cause. So if you are bleeding heavily after delivery or passing clots, several large clots, then this is a warning sign. Sepsis is another major issue. So if you have high temperature, this is a key warning sign. Now, abdominal pain. It's not unusual to have some abdominal pain immediately after delivery, especially the after pains. The uterus is still contracting, and that is what, you need the uterus to contract very well to reduce the likelihood of bleeding. But if the pain continues to increase intensity, then that is not normal. It needs to be investigated. Foul-smelling vaginal discharge. The lochia should become, initially it's red, then dark red, then brownish, and it should be reduced in quantity, But if you now have foul-smelling vaginal discharge, that can be an indication of sepsis. Chest pain, shortness of breath can have, be an indication of pulmonary embolism. These are some of the leading problems that you can have. Dizziness, fatigue can be a sign of anemia, that maybe you have lost more blood than necessary. And then persistent severe headache can be associated with severe preeclampsia. Now, next slide. Now, what can you do as a woman in the postnatal or postpartum period, navigating that? You need to eat properly, vegetables, whole grain, and so on. I'm sure when you are asked, balanced diet, all of us, we can recount it. But the thing is, in practice, do we, eat balanced diet? Or is it all eba and rice all the time? We need to drink adequately. We need to rest. One major issue is many women don't rest adequately during the postpartum period, either because the assistance they need is not there, or they are still trying to cater for the grandmas. Some of them will insist that they want pounded yam, whereas the woman has just had a cesarean section. So, here we need our partner's support, because oftentimes they are the one that bring all these visitors, to celebrate. It's good to celebrate, but, the men should learn to protect their wives because they need to rest. You see, when all the visitors have gone, your baby doesn't know whether it's morning or night. At night, the baby can keep you awake, and you need to attend to your baby. So you must create time for rest limit physical activity, pay attention to perineal hygiene. Now, mental health support. We talk about maternal blue or maternity blue, which usually occurs around the third, fourth day. And sometimes this can progress to depression. Okay? So, and this needs to be picked up early so that appropriate help can be given. Next slide. I will talk briefly about maternal mortality and morbidity. Now, pregnancy is a thing of joy, but sadly, unfortunately, it's not every woman that, go through that process successfully. As a matter of fact, at least 8,200 women die annually in Nigeria in relation to complications of childbirth. Nigeria, unfortunately, has the highest maternal mortality ratio in the world. Now, it's not also about maternal mortality. It's also the morbidity. So, because it's not everybody that dies, but the causes of mortality are similar to the causes of those who manage to survive. Morbidity, ill health, subsequently. Sepsis, being in hospital for weeks, and so on and so forth. The other thing to note is that the common causes, which include hemorrhage, eclampsia, sepsis, obstructed labor, complications of unsafe abortion, anemia, and so on, are preventable. They are all preventable causes. So, which means something can be done about it. So, and this now comes back to the issue of antenatal care, our health-seeking behavior, and of course, we also need to, the political will. We need to demand more from our political leaders to make sure that the facilities are there, for our women to facilitate access. Most of us have to pay out of pocket, and again, we said there is poverty in the land, but poverty does not mean that your wife cannot get pregnant. And if there is an issue, there is no money. So there are things that government should be doing, and we should demand from them, to do such things. So prevention, optimal health, good antenatal care, good delivery care, and of course, let's pray that we will not be victims of circumstances. Now, next slide, please. Like I said, it's like, an overview of, from womb to wisdom. So, but we're getting somewhere. We're going to talk briefly about menopause. I think that you may have omitted. Please look for that. There's a slide that's missing. I think you've jumped. Yes. Okay. So menopause. What is menopause? Menopause simply means the end of having menstrual period, the end of menstruation. Okay. On average, it occurs between 48 and 52 years. Okay. So, and increasingly, since people are living longer, it means that more people are being affected by menopause. And so the menopausal years are becoming increasingly important. Now, if you cast your mind back to what I said about the ovarian capital, okay, so this is a stage where the bag of oocytes, that's the eggs, and the cells that produce hormones have become depleted, and therefore is characterized by 1, no more ovulation, 2, the hormones level, go down, And there are consequences of that. Now, we define menopause as cessation of menstrual period. But before that, there is a phase where women, begin to experience some of the signs, premenopausal signs. Okay, usually by 45, even say, menopause on average 50 years. And some people actually go through menopause sooner, earlier. Anything after 40 is considered as normal. But before 40, it will be termed as premature menopause. So the consequences of low circulating hormones include symptoms such as menstrual problems, irregular periods usually, hot flushes, night sweats. These are called vasomotor symptoms. Poor sleep, and then you have vaginal dryness and painful sex, dyspareunia, reduced libido, and then you have effects on bone formation, fractures, and so on. It's also believed that the hormones are protective of our heart function. So you tend to have increased prevalence of cardiovascular problems in the postmenopausal years. The mood changes, anxiety, depression, poor memory. These are some of the things that characterize menopause. But you know that menopause occurs at a time in life, the so-called mid-cycle, between 45, 65 years. So there are some clustering of life events. There are other things that can affect the way menopause then presents to you. Issues with body image, retirement, which also means less money, your influence dwindling, your circle of friends also reducing, spouses, losing a spouse and so on and so forth, or they become ill, health challenges, then children going out of the house and concerns about the children. So these all come together at a time when the woman is vulnerable because of the hormonal changes as well. And of course, some have to deal with certain disease conditions such as obesity, hypertension, which they didn't have in their younger years, diabetes mellitus, osteoarthritis, and cardiovascular diseases. Next slide. Yeah, this slide just, I think we are jumping. Can you go back a bit? Go back. So, this just basically summarizes events around the menopause. So, you can see that virtually every system is affected. So, menopause is indeed a very important, but unfortunately, when you talk about knowledge, awareness about menopause, the level of awareness is very poor. What you do and how to manage menopause is very low, especially in our environment. Part of this is because people have other issues to deal with, and so they just let it go. But the other things also is that you may think you are alone, or sometimes people think it's a spiritual attack or some other form of attack. But these are reality, that we go through. So knowledge is power, and wisdom is the correct application of knowledge. So let's look at what are the management options for menopause. Okay, these are the management options. Most of our mothers, the older ones, they just went through menopause and that was it. Earlier, the our teacher was telling us about the fact that even in your menopausal years, some people think that once the period stops, you shouldn't have sex again. So again, that could also be reinforced with the fact that even if you try, you may have, because of dry vagina, you may have pain, and therefore you just forget all about it. So it could be expectant if there are no issues, but we need to be educated. We need to be reassured that what is happening is, physiologically normal. And there are some situations that you need to exclude malignancy, because some people are fearful that maybe because their friends died of cancer, they too may be having cancer. There are, apart from counseling, there are drugs that can be used, that can be prescribed by specialists, pharmacological agents. That's what we call hormone replacement therapy, because at the center of menopause is reduced hormones, particularly estrogen hormone. Now, the sort of hormone we use are actually weak hormones, but they do the job. Weak in the sense that we don't want them to cause harm. And this comes in various preparations. It can be tablets. It can be locally applicable, something you can apply into the vagina, for instance, to help with dryness, with soreness, and so on. And there are those that are tablets. But for some women, it may not be appropriate to give them hormones. Those, for instance, who have had breast cancer, or those who have had DVT, cardiovascular events. DVT stands for deep vein thrombosis. So those ones, because estrogen will increase, especially systemic estrogen, may increase their risk of, breast cancer or embolism. So in those cases, there are drugs that can be used, such as clonidine, that can reduce the vasomotor symptoms that some women experience. But like I said, counseling is important. And then many of us are familiar with health screening. Now, it's recommended that when you are, some will say 40, but at least certainly 50 and over, it's recommended that you should have an annual health screen. Annual health screening. Many people don't do this. And during the screening, the doctor, there's some questions the doctor will ask you, will examine you, check. The main things we check will be urinalysis, blood sugar, liver function test, lipid profile, renal function test, ECG, and chest X-ray. Now, the prevention is better than cure. So don't wait until there is a problem. There are also screening, particularly for women, pap smear, which is intended to reduce cervical cancer. Again, sadly, in our environment, a lot of women are still dying from cervical cancer, whereas elsewhere, because of, they've gone from, pap smear on its own, reduce the risk of cervical cancer to very, very minimal. But they've even gone beyond that. Now they are giving vaccines, to, young ladies, 9 to 13 years old, so that before they become exposed to human papilloma virus, they are protected. God will take us there, but there is a lot that can be done, from the preventative side of things. So what can I do as an individual? It's not everything that is tablet. Lifestyle modification, very important. Okay, lifestyle modification, dietary changes. Again, diet is a recurring matter in health. And that's because we are what we eat. So we must pay good attention to our diet. Supplements, including vitamin D, limit processed food. Because processed food contains preservatives, contains high sugar, and so on and so forth. Then regular exercise. I believe these are things that we know, but maybe we're just reminding ourselves. Drink water. Water is good. Drink water. Get enough sleep. I don't know, how many of us get 7 to 9 hours of sleep daily? Get enough sleep, because the issues with vasomotor symptoms and so on, if you don't get enough sleep, everything will go haywire. And avoiding alcohol and caffeine. Alcohol, obviously, for most of us, is no-no. Caffeine is not only in coffee. I know some of us binge on coffee, but be informed that the caffeine in it can upset your system. But it's not only coffee. Tea also does contain some amount of caffeine, as well as Coke also contains some amount of caffeine. What more can I do? Building a network of support system. As you get older, maybe we actually should start, even in our younger years, making preparation. Have friends, that you will continue to maintain friendship with, even in your old age. Be good in your family, and if you need, have regular health care providers where they know your history. Take control of your health. Make your health a priority. Find a purpose, for living. We must establish a purpose for living. We must get involved in community activities. So we're not living just for ourselves. We're living for God and for humanity. So let's find purpose for living. Menopause does not mean it's the end of life. It's just a phase, another phase in life. So we must take it as that. Our spiritual health, very important. And that's why I like the theme of this year's conference, which is Abounding in Hope. And Colossians 1:27 talks about Christ in you, the hope of glory. Have faith in God, and then forgive. Forgive. Some people carry the burden of forgiveness, and it can be very difficult to deal with. Stress management is very important. Things that is going to cause you trouble, don't embark on them. So don't look for trouble for yourselves. Now, if trouble comes, on its own, because the Bible says in the world you will have trouble, but God has overcome. So put your trust in God. Philippians 4:6 says, be careful for nothing, but in everything, by prayers and supplication, make your request to God, and that the peace of God, which passes all understanding, will keep your heart and mind through Jesus Christ. So, in conclusion, can we have, yes. So there is no doubt that the women, women occupy a central role in family and therefore in society. So their health is very, very important. They are our sisters, our daughters, our wives, our mothers, grandmothers, nieces, and so on, our aunties. So now, there is no doubt that reproductive health in women is very, complex. I won't say complicated. It's very complex and potentially complicated. And it's not just starting from childhood, but from intrauterine life. And every stage is important. intrauterine life, childhood, adolescence, the reproductive years, and the postmenopausal years. So, but we must know that we are not alone. There is always, we must have understanding of what is going on, and that, God is with us through this journey. So I hope we can have some time for questions and answers. I've tried to sort of run through what I consider important in reproductive health in women. I want to say thank you for listening. Can we have... thank you.
Thank you very much, sir. Can we please put our hands together? He has given us 41 years in like 50 minutes and 38 years of experience in this field, attending to you and I. Let's give it up for him. Please, let's put our hands together for the professor. Thank you very much, sir. Thank you. God bless you, sir. We are grateful. That was a real lecture. If we have to pay for that, I wonder how much that will be. Thank you, sir. We are grateful. Earlier on, while I was introducing the professor, I forgot to mention the backbone of professor, the rib, his special one, the one who has stood by him. Imagine 41 years, stood by him, watched him, prayed for him, nurtured him, fed him in all ways. I'm very sorry, ma. I'm on my knees, ma. Most sorry, ma. Please, can we put our hands together for Mrs. Olufolakemi Ola? Please stand up, ma. Please stand up. It's not easy. It is not easy. Thank you. Thank you for the behind the scene, holding it strong. I'm grateful. Thank you so much. Apologies. Is it accepted, ma? Thank you, ma. Please, let's clap for her, please, so that they can pay me my money in full afterwards. Thank you. Now, questions. Questions. He touched on everything. And I know most of us can relate. Some of us have, some people are going through secondary infertility. This might be the time you can air that. Challenges around fibroids, the running away, as he said, is not death sentence. As my mother used to think, no, it's no longer that. Science has moved forward. God has helped. God has raised men. And from what he started with God, it takes, when you go to professor, just know that you have everything in one. There is God in it, and there is knowledge in it, and he even knows the correct application in it. Please, let's put our hands together for Professor one more time. So questions now? Questions? Pardon? You have one? Okay, please go ahead.
All right, thank you so much, sir, for the teachings. I want to know, is it medically ascertained that family planning can cause cancer? Can family planning cause cancer?
Thank you. Sorry. Thank you for the question. I think the broad answer is no. That's the broad answer, is no. Now, those using combined oral contraceptive pills, because they contain estrogen, prolonged use, may be associated with increased risk of breast cancer. And we're talking about prolonged use over, 10 years. But, the other thing that things like family planning and HRT brings up is the fact that you tend to have increased surveillance. And therefore, it's likely, if there is any issue, that it will be more readily detected than if you are not on any of those. But family planning, there are many methods, and I ran through them. So it's not just combined oral contraceptives, okay? You have other things, and as a matter of fact, if you are, the combined oral contraceptive pills tend to be used more in the maybe younger years to either delay having babies or to space them out. Now, in the later years, people tend to use more of the IUCD, which is the coil. These are long-term contraceptives, as well as the injection and the implant. So these have actually been found to protect against certain types of cancer. That's injection and implant and injections and the implants. Yes, they are protect. They protect against certain types of cancer.
Good afternoon, sir. Thank you, sir, for the teaching. I just want to ask, sir, what normally causes the heavy bleeding at childbirth, and what can somebody do during that period? Because I think this thing normally causes untimely death. Thank you.
Thank you, ma'am. This is what we call postpartum hemorrhage. Now, when a woman is pregnant, as a way of providing for the baby, the blood flow to the uterus is increased so that there could be more flow of nutrients and oxygen. Now, the way the placenta is placed is placed on the uterine wall, and the mother's vessels supply blood directly just to perfuse the placenta. Now, once a woman is delivered, the placenta comes away. Okay, so which then means that those vessels are now left open. Okay, so it would then be necessary for something to close those vessels, otherwise the woman will bleed very heavily. So the uterine wall, so those vessels pass through the uterine wall, and the uterine wall have fibers. Those fibers must contract, like when you tie something with rubber. So they are called live ligatures. So those fibers must contract around the vessels to stop the bleeding. If this fails to occur, the uterus is not contracting well, then that is the commonest cause of hemorrhage. Okay, and this can be associated with gram multiparity. People have had several babies, 5, 6, 7, 8 babies, because as time goes by, the uterine wall becomes weaker. That's just, a layman's way of explaining it. And therefore, they will not contract effectively. All right? So, it can also be associated with twins pregnancy or multiple pregnancy because the uterus has been overstretched. Or it can be associated with things like big babies and so on. Then women who have had previous history of bleeding in pregnancy, during childbirth, should also be washed, So the important thing will be to deliver in a good place so that normally, and again, prevention is easy and relatively cheap. What you need is to give drugs that will make the uterus to contract very well. If this is not done, then the woman stands a risk of bleeding. Oxytocin, misoprostol, these are relatively cheap drugs that are available. Any unit that is conducting deliveries must have them, and they are given routinely. You don't wait until the woman starts bleeding. You give them the drugs, anyway, to help the womb to contract. Other things that will help will be breastfeeding, and also because breastfeeding makes you to produce a hormone called oxytocin that will make the uterus to contract better.
Thank you, Prof, for that insightful lecture. Sir, on this issue of fibroid, I got engaged in a conversation with a colleague in the office. I know she had this fibroid issue. And she was now telling me that for the fact that you have given birth to children doesn't mean that you cannot get that, you cannot be a victim of that fibroid of a thing. You've mentioned some symptoms. If one is not having any of the symptoms, is there a way to check whether she has fibroid or anything that can relate to that? That's my question, sir.
Thank you for that question. Now, during the course of my presentation, I did mention that majority of people who have fibroids don't know that they have fibroids. As a matter of fact, from the statistics we give, at least 1 in every 3 of us sitting down here has fibroid, okay? But most don't have any problem with the fibroids. So if it's not causing any problem, some of the problems we've outlined, one is infertility, the other is period problems, the other is if you have a big tummy that's causing pressure symptoms. So those are the reasons that you may want to remove fibroids. However, if you're not having any symptoms and you have a fibroid, probably detected, by scan, just coincidental. Some of us now go for annual checks, and we may find, somebody mentioned, oh, there is fibroid there, and then we'll go and see gynecologist. Well, it's okay to see gynecologists who should put things in proper perspective. It's not every fibroid that needs to be removed, okay? So if it's not causing problem, if it ain't broken, don't try to fix it. So you can live with it if it's not causing any problem. It is not cancer. I think that's one of the first statements also we made about fibroids. So don't worry about it. A lot of women have it, and you can live with it. All the questions are coming from.
Thank you very much, sir. Now we'll take the written questions. Does any other person have questions? Okay. Sir, I am 48 plus years of age this year, and by January, I'll be 49. And for some times, my menses has been coming once in 2 months. But since March, I have not seen it. But ever since, I have been having pains in my thigh and back. What can I do?
Thank you for the question. Again, when we say menopause, it's a, periods, cessation of period. Now, how that happens differ from one woman to the other. It can just stop, and that's it. But for most women, you may have a period where it becomes what they call shege, irregular. It comes, maybe it got spaced out, like the case that was presented that, 2 months instead of the monthly. And then subsequently, since March, which is now 4 months. So it may well be that, that is what is going on. Now, as for the pains, the cramps and so on and so forth, that should be checked out. See a doctor just to make sure that other than the premenopausal association, there is not something else. Once that is clear, you may wish to consider, HRT or, supplements such as calcium, vitamin D, and so on. But it just needs assessment to make sure that there's nothing else.
Thank you, sir. Next question. I removed my IUD of 2 years this year, January, and I started meeting with my husband from May due to distance, and until this moment, no pregnancy yet. What could be the reason?
I heard something about distance.
Yes, sir. I removed my IUD of 2 years this year, January. And I started meeting with my husband from May due to distance. And until this moment, no pregnancy yet. What could be the reason?
Okay. Now, there are many complaints of that question. One, I'm not where the age has not been stated. That can be an issue. The other is, you said since February. This is...
Since May.
This is... since May.
Yes.
Okay. And this is July.
July.
So 2 months. So before we say, this is infertility, 1 year of regular sexual intercourse. And when we say regular, we don't mean once a month. Because you mentioned distance, and I'm not quite sure whether he's saying that the husband lives in Abuja and she lives in Lagos. So, because this is another challenge in modern living, couples not living together. Okay? Now, if you understand the ovarian cycle very well, a woman ovulates on average once a month. Once a month. About 12 to 13 times in a year. So, and the egg is available for fertilization 24 hours. So if it doesn't happen that 24 hours, it just degenerates. So what then needs to happen is that, regular intercourse needs to happen. Now, from the fertility point of view, we recommend 3 to 4 times a week as being adequate. I know our previous teacher recommends every day or probably twice a day. Now, when God made them, he put them together in the Garden of Eden. What did he stay in Abuja and the other in Lagos? So, coming at the end of the month may miss the boat. Yeah, if the woman had ovulated 2 weeks ago, you're just coming from Abuja, just for companionship, but not, so that can be a cause of delay. But actually, we don't investigate infertility until couples have had, unprotected intercourse regular for a period of 1 year. The reason is this. One is that even given a perfectly normal couple, pregnancy does not occur at the very first month. There is a probability or chance issue there. Okay? So, but by the end of 1 year, most of those who don't have any problem would have achieved pregnancy. So, you can then focus on the ones that are remaining, in which you are likely to find an issue, and which you can then treat. See, because you don't just, they say if it's not broken, don't fix it. There are consequences for treatment as well, but you can justify those consequences if there is a need. I hope that answers that question.
Yes, thank you very much, sir. We have 2 more to go. Are there anxiety attacks, panic attacks part of menopause symptoms? Anxiety attacks and panic attacks, are they part of menopause symptom?
Well, it's something that, has been mentioned, but like I also try to point out, there are a lot of things that are happening around the period of menopause. Reasons why many people can be anxious about the children, about so on, and about their spouses, about money, and so on and so forth. So, so sometimes it's difficult to see, which one is hormonal based, which one is, as a result of socio-economic circumstances, and so on and so forth. So all these, counseling is key. Counseling is key. Once you see your specialist, you can discuss all this. And, it may be beneficial if you can't find anything else to offer, either hormonal or non-hormonal treatment in such a case. But, you cannot really say that. I mean, if somebody wasn't having that before, you need to actually look at life circumstances, what has changed. And if you can't find anything, then it makes sense to try on treatment.
Thank you very much, sir. Here's the last question. Please, is there any relationship between genetic compatibility of partners and getting pregnant and the pregnancy actually staying full-term? Because the lady in my area said she was told that her gene and that of her husband is not compatible. As a result, she miscarries. Please, sir, throw some light.
Now, recurrent miscarriages, sometimes we can have issues. Some may bother on genetic. We do sometimes send people for karyotyping, for instance. But it's rare. It's a small part of, causes of recurrent miscarriages. But yes, there are some issues that may be due to abnormal karyotypes, that is abnormal genetic makeup, abnormal chromosomal makeup, and so on. So if you have a case of recurrent miscarriages, there is a way of investigating them formally. It's not just about genetic composition. I don't know the particular case, but yes, there is a small proportion of recurrent miscarriages that are due to genetic issues or genetic problems.
Okay, sir. Do you mean by resource factor?
Where resource factor is, it's partly genetic, but that is a specific condition which has to do with blood compatibility between the baby and the mother. Okay, but what I'm talking about, if you're talking about recurrent miscarriages, for instance, is things like, translocation of the chromosomes. You find a situation where even though the partners appear normal, but when you look at their chromosomes, you find that there are some abnormalities that have been corrected for. But when then they come together, it then becomes manifested in the fetus. And that may determine whether, the pregnancy survives or not. So, but this is something we do. We are mindful of whenever we are doing, whenever we are investigating people for recurrent miscarriages or recurrent pregnancy losses. There are other things such as immunological problems that we look at. Then we also look at other things like, hormonal problems, diabetes, and so on and so forth. Structural problems, such as looking at the wombs, and so on. So, but that's, that's a subject on its own.
Thank you, sir. We can keep doing that till he gets to his seat. Thank you so much, sir. Thank you. Chosen women, have we been blessed? Really, really blessed. Then let's put our hands together properly. Thank you. Now we are at the point where we proceed to item 7, but we have to go through it orderly. We'll be taking the tables of our invited speakers first, then we go over to the elders. And this is also important. Please, your table will be approached by an usher to proceed to the stand. If you want to eat rice, please go with the plate before you. If you want to swallow, just go over there. There's rice, there's amala, there's semo, I believe there's There's a father. Yes. So if you know you want rice or father, whatever kind of rice, please go with your plate when they get to your table. But if it's swallow, please, when you get there, then you take a plate for the swallow. We are moving orderly. Please, we are starting with the table of our invited guests. Then we move out to the elders, and subsequently our tables will be approached by an usher. Please, you're only entitled to a meal. Either you have the rice or you have the swallow. So they are going table by table. Please, if you know you're outside and you can hear me, please come in and be seated. It's done table by table. Thank you very much. While we are approaching the meal table, we have some special people who came in, the first 5 people that came in here this morning. The Chosen Women Committee would like to appreciate you for coming early, for taking your time to be part of us, and you're still here. Sister Kemi Badejo, please, where are you? Sister Adaora, Mrs. Adaora Olori, and Sister Olowo. Yes, Arowo Shala. Thank you. Thank you. So, okay, yes, please. The first 5 people that came in here this morning. Sister Kemi Badejo's eagle eye spotted you, and she wants to give you something.
All right. I trust we've all been having a very good time in God's presence. If we've had a swell time today, I just want to say hi. Nice. Okay, so I'll be starting, like I said on the group chat, that I want to see those that will enter into my first early bird list. And I have 5 wonderful mommy and sisters. The first person on the list is Mommy Oyewole Oluwakemi, our praying mother. Thank you, ma. God bless you. More anointing, more grace. Then the second person is Sister Okpemipo Ogunsanwo. Again this year. Thank you very much. And the third person is Sister Tosin Adio. Hey. Their mothers were yet, they woke up early, get the house set, and they were here. All right, thank you. God bless you. And the fourth is Sister Laide Ojo. She has been telling me since yesterday, Sister Kemi, I will stay around here. I go nowhere. I'm coming very early today. I'm sleeping Agege. It's our All Sisters Conference 2025. Thank you very much. God bless you. And last not the least is Sister Debowale Olubumi. I don't know if she's still around. Okay, she has gone. All right, so I'll keep her gift for her. So that takes me to the most anticipated award-winning time. Like we did early in the month, the subgroups, right? Yeah, so people want to know who the first and the second subgroup winner is. So for our visitors, let me just explain this aspect. So we have a platform, the Chosen Treasure platform. That's the Women Fellowship of the church, where we talk, communicate. So we also have subgroups in the fellowship. And we encourage our sisters to register. So we did like a marathon race for the highest number of people in that subgroup that have registered for this conference. So based on what our CBN official gave to us, Sister Toyin Agomi. So we have, I'm going to start from, before I call the second and the first, I'm going to start from the 7th position. We have 7 subgroups. So, the 7th position is Throne of Love. Let's clap for them. Yes. The next, 6th position is Throne of Grace. Let's clap for them. The fifth position is throne of peace. Let's clap for them. This one pay me. Oh. It pay me. And it's because I'm in that subgroup. That's throne of joy, the fourth position. Throne of joy, clap for yourself now. We tried. Yes. And the third position, throne of victory. Now, it takes me to the first and the second. Who would it be? Is it throne of glory or throne of mercy? May I say that the first position is throne of glory. Please, let's celebrate them. Woo, 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 woo. Woo! And the second is throne of mercy. Throne of mercy, please come forward. Throne of mercy, let's have you come forward, please. Throne of mercy. Where are the representatives of throne of mercy? Throne of mercy, come forward, come forward. Hey! God bless you. Thank you, mommies. Thank you, sisters. The truth is, without you all, without your contributions, without your participations, without your presence here, All Sisters Conference would not be a success. And on this note, we just want to say thank you for your support, thank you for your contributions, thank you for the registration, everything that you are even seated here. We are saying a big thank you. Please celebrate yourself and give yourself a round of applause. God bless you. Like we will say in Pastor Obabori's voice, God bless you really indeed. God bless you. Thank you very much.
Please, let's put our hands together for Sister Kemi. Sister Kemi is the human alarm clock. She's an alarm clock. She's a diary. She's always on our necks. Please, let's put our hands together for Sister Kemi. Sister Kemi, thank you for the good work. Thank you. Thank you so much. While the food is going on, we have, you know that from October, every year in this church, before we get to December, like from the 1st of October, we tie a lot of gillies, women. That's when you see all the colors. This green, you will see like 17 shades. That day, when we start to do what's it called? Our independence celebration. Then from there, we transition to December. In between, I think elders will hold their programs and they will tie gilly too. And we always have people at the back. I, for one, I used to run away because the sisters won't let you rest. I want to tie gele. Come and tie gele for me. Sister Martha, tie gele for me. Sister Kweshe, tie gele. Now we want to help you so you can help yourself. Clap for yourselves now. You don't want to help yourself. At this time, Sister Fumilayo Kweshe will be teaching us how to tie the gele while we move from table, while the food is going on. So please, I'm begging in advance. I'm appealing in advance. If you come to me, I will report you to Mommy Obabori. This is the time to learn how to tie your gili. How to layer it, how you do is it not the sigo? What's the name of that style now? All the Orishi style, you will learn it here now. So sisters, please, while we are going for the food, the gele lecture, the gele class, learn now, learn. In case, you never can tell. Tomorrow, you can decide to jackpot. It can fetch you money. I think it's 10 pounds to tie gele. How much is it? How much, please? 10 pounds or 30? 10 pounds to tie the gele. Then 20. Someone said 20. Then if you are going to tie it in the US, I think you have to pay 50. Am I correct? See people calculating money. Women and money. I'm talking about pounds, and everybody is calculating. Anyways, this is the time to learn. Imagine just going to an occasion, no one bear, and you're tying gele for 5 people. You've made 50 pounds. You're tying gele for 5 people. You've made $250 if you're in the US. And while you are here too, you never can tell. Everywhere, markets. So this is the time now. Please, let's pay attention. And we need a volunteer, sister with a very nice head. Glorious, gorgeous, beautiful. You can volunteer, come forward. Let's use your hair to practicalize now. Thank you. If I say there's a gift now, everybody will rush out. Just one person. Thank you very much. Please, let's put our hands together for her. You will get another award again next year. You get another one before you go again. Sister Kwesheito. Any empty? We are ready for you.
Good afternoon, everyone. My name is Fumi Okpesheiton. I'm a beautician by profession. I'll just be teaching us two simple gele to tie if going out or coming to church. The first is 2-in-1, which can be in turban style, converted to round gele, while the second is take a bow. We call it take a bow. It's just a rose by the side. So, sit back and learn. Our model, thank you. So this is a normal ashoke. Let's go. Okay, the TV is clear now. The TV is clear. So this is normal ashoke. Ashoke is a local name we call it, but some people call it. Which other name do you call it in your tribe? Ofi, yeah. But ashoke, popularly known. You can use this style I'm about to tie. You can use your normal sego, but the finest for it is ashoke. Ashoke comes in different length. The longest, which is the best for gele, is 90. But because of everybody trying to make money now, people reduce, so you can get the shortest to be like 60. If you're tying 60, for example, let's say the gele is short, you use what we call 30-70. Can you all hear me? 30-70 measurements is folding the gele into 3 parts, like this. This is 30-70. But if the gele is long, now there is a size of 70. If the gele is 90, you do what we call 50-50. 2 equal parts. 2 equal parts. That's how you would tie. And if the gele is between 70-80, some people, it's not determine the size of the head. I'm sorry to say this. It's determine. So, as a makeup artist, when I'm tying gele, I look at my customer first. I'm sorry to say, but some people's head are actually a bit bigger. If it's a smaller head, then 50-50 will go. But if it's a bigger head, you still do your 30-70 for 70 inches. So let's not talk too much. Let's go to the plan of the day. So we are tying like a simple turban now. A simple turban. not okay to tie like this. So you fold a simple edge. Just a little folding. If you cannot see well, you can look at the screen. So you fold the edge like this. Now I'm tying 50-50 for her, for a turban. Remember I said this is like 2-in-1 gele style. So I can convert the style to either turban or to round gele. Do you understand? Now you see some people do cross at the front of the gele. It's called V style, V round. So it depends on what you just want to achieve, but this is not a technical class. It's just a simple basic gele that you can easily wear to church. So I'll just do the normal round style. We do what we call pleats. This finger, the thumb stays on the gele, 2 fingers under. Thumb stays on the gele, 2 fingers under. You start your pleat. Creating a pleat. So make sure the pleat stays, then you place it on the person's head. No, I'll tell you when to hold it. If you are tying for yourself, holding it, there is a technique we use in holding gele. To cross at the back, I wish, okay, I will still tell you to stand up. Now when tying gele, please make sure that the gele is covering the ear when starting. Remove your jewelry because you can hurt yourself while pressing it down to the ear. Remove your jewelry. When you are done, you remove the part that has the hair hole, then you fix in your jewelry. If you are the one tying by yourself, if I'm the one, I will use my neck. It's not easy. I'll use my neck, press it down to do this part. So I'll use my neck to hold the longer part that I'm not using for now. Then I'll start with this part. Then you start creating your pleat. You start your pleat from the back. From the back. Camera, please. I don't know if you can come towards this side. Okay. Yes. So you are creating your pleat. You are picking from the back and taking it out. Pick from the back. Extend it. Then you continue with the pleat. You get someone to hold this short hand for you. Have you held it? Probably I'll still tie it on my head so that you understand better by myself, because I think the idea is that you want to create it by yourself. Yes. So if I'm doing a turban, I'm almost done. I'm almost done. This is the first step to the turban. If the hand of the gele is big enough, I can tie. But the hand of this gele is not big enough. So I'll pin it. These are the two hands. These are the two hands. I drag them together. We are almost done. Just need to set it now. You need lots of pin. Then at the back, you just make something we call rows. And that is all. Then you push this part back for the edges to show. That is all for your turban.
Let's put our hands together. Does anyone want to try by themselves? Everybody say, I will not tie gele for you come October and December. Do you want to try?
I'll quickly show you the, you want to snap it? Sorry. I want to show them the take a bow. That's the easiest one.
Our model.
Extra effort for you. Okay, you want amala? Oh, Father, please, the caterers, take notes. 2 leaves.
I believe you're enjoying our meals. They are going table by table. Please don't finish it.
But take a bow, as the name implies, it's just at the side. So all you just need to do is take it from the back. Fold the gele into almost 2 equal parts. You can do that yourself. It's very easy. Take your bias by the side. So we are going to twist it, the entire gele together. You don't need to tie. but hold it firm. Is it firm? Sorry, ma. So, this is the first step. I twisted it once. So there are two hands. I start forming what we call rows. It's just taking it round. But in the round part, you have to be intentional to make it lovely. So you pin the last edge. Did it? Just one pin. Turn the first one. So you are creating the second rows. You take it from the under this time. Remember, you pin the last part too. When pinning, don't pin outside, pin inside. Take a bow depends on the person. If you are the extravagant type, you can leave it very wide. Take it a bit back. Now you can style it this way. These are the rich auntie vibes. So the back, you just fold and pin. Or you can reduce it. Which of it are you rocking tomorrow? This one. So the steps are, you just take it from the back, you twist it together at the front, you just keep going round, like you are forming a rose. Just be intentional that you are picking each of the steps of the gele. When you do that, the second hand, you take it from the under and take it round, and you just pin the needful areas, and you are good to go. So this is take about, within 3 minutes you are done with this gele and you are good to go. There's another one they call icon, but there's no time. It's almost the same thing, but that one forms like a petal when you do it. Thank you very much. Do we have anyone else to try take a bow? I know the first one may be kind of somebody.
Ma? Pastor Vincent. Thank you, ma. We are taking a bow. Thank you to our model. Our model wants offered rice. Let's put our hands together. Thank you very much. The media department, please be prepared. But while we wait for you, we want the ESCOs, the women ESCOs. Have you taken a picture of this? So please come and take a picture with our guest speakers now. While the media are trying to put the... Let's put our hands together for them. ESCOs, committee, ESCOs, women. Is the movie ready? They are not ready. Are they ready? I can't hear you, please. All right. While we have our meals, please let's enjoy the movie. Thank you. At least I'm going to eat myself.